with us, or maybe not your first hour, but this hour anyway. I'm Holly Brenner, and I'm grateful that you're here. We have a great presentation for you today with Dr. Adam Liss. I will do his introduction, but I'll keep it pretty brief because I know in his presentation he has some information for you. But we'll start out with a reflection. And I don't see Jim Mugen in the room today, but this is courtesy of him. It's one of my favorites. It's one he shared at a recent meeting, and I just thought it was very good. So hopefully you agree. It's called The Best Poem in the World. I was shocked, confused, bewildered as I entered heaven's door, not by the beauty of it all, nor the lights or its decor, but it was the folks in heaven who had made me sputter and gasp. The thieves, the liars, the sinners, the alcoholics, and the trash. There stood the kid from 7th grade who swiped my lunch money twice. Next to him was my old neighbor who never said anything nice. Bob, who I always thought was rotting away in hell, was sitting pretty on cloud 9, looking incredibly well. I nudged Jesus. What's the deal? I would love to hear your take. How'd all these sinners get up here? God must have made a mistake. And why is everyone so quiet, so somber? Give me a clue. Hush, child, he said. They're all in shock. No one thought they'd be seeing you. Judge not, every saint has a past. So when you see Jim Mugen, let him know that that was a pretty cool reflection. We do have our regular housekeeping things, familiar items in front of you. We have information for our next No One Go Friday, which will be Friday, August 12th. Dr. Royce will be here with us. We also have information, your comment cards, so please continue to fill those out. We make changes every month based on your feedback, so we appreciate that. And then if you're interested in winning, looks like a duffel bag, thank you, Katie. Please fill out this green slip and we'll pass them over to your right later in the program. One new announcement, this is the last month that we'll be doing the noon No One Go session. We've tried that now for a couple of years and with varying levels of success and attendance, measured basically by attendance. And we've decided to work smart that part of our program, and we'll be continuing with the 8 o'clock session, but today will be the last noon No One Go session for you. So please spread the word on that, although there aren't too many people who you need to tell. Anyway, we'll move forward here. Dr. Liss is with us. Thanks for being here, Dr. Liss. Dr. Liss is a radiation oncologist. He's been here for about a year and a half with the Agnesian Cancer Center, graduated from Penn State University College of Medicine, and completed his radiation oncology residency at the University of Michigan. So with that, please help me welcome Dr. Liss.
Thank you, Holly. Hopefully everybody can hear me okay. If I understand people at the satellites tuning in can text Katie if they have questions. If anything comes up, you can't hear me, you can't see the slides, please text her as well. So I was, as Holly alluded to, I was going to give a little bit of introduction myself. Today we're going to talk about men's health and its relationship to cancer. Before getting into that, I wanted to again give a brief introduction. This is a picture of pretty much the radiation oncology team at the Agnesian Cancer Center. You can see my partners, Dr. Troike and Dr. Vanderkoy, my nurse, Mary Lorenz, who's in the back. Not pictured as me, and that's because I'm the new guy here. So I figured I'd give you a little background of how I came to Fond du Lac. I was born in Milwaukee, just south of Milwaukee in Franklin. Don't look at the arrows, they're a little bit off there. This is where I'm from. My wife is from Anago, Tammy, and we met at the University of Wisconsin in Madison. I was, after my undergrad, I was working in the lab doing cancer research, and my wife was completing her PhD in mouse cancer genetics. So she started working on mice with cancer, and I ended up treating humans with cancer. So it was a good match. From Madison, I had to chase her around quite a bit. She took a position at the National Cancer Institute in Washington, D.C., so I decided to go to a med school pretty close by there, which was Penn State. During my second year of med school, her lab was recruited to Singapore. Singapore was spending a lot of money on cancer research, and it was a good move for her to go out there. So I was able to take a research year between my third and fourth years of med school and go to Singapore with her. So that was a big jump for us. I chased her all the way around the world. This is Tammy and I on a beach in it's Thailand, actually. We started our family in Singapore. Our oldest daughter was born out there. And finally I convinced her to start following me around a little bit. So we returned to the Midwest, and I completed my residency at the University of Michigan. in Ann Arbor. That's where we completed our family, and you can see our 3 girls. Sydney's 7, Violet's 5, and Hazel is 2. And we both wanted to come back to Wisconsin and raise our family. This is where we're from. This is where we wanted our girls to grow up, and found an excellent position here in Fond du Lac at the Agnesian Cancer Center. So just wanted to let you know who this new guy is, talking to you and giving you advice on cancer screening. So I suppose we can get started with that. There's really 2 key points that I want to talk about before getting into screening and prevention, and those are there's really 3 principles of screening, but I'm going to talk about the first 2, and that's primary prevention and secondary prevention. And basically, primary prevention is trying to prevent a new disease or cancer by reducing risk factors, changing your lifestyle so you're never diagnosed with a cancer. That's the best way to prevent cancer. That's primary prevention. Secondary prevention is detecting a disease or a cancer in its earliest stages, when when we have the best prognosis when treated. And I'll mention both of those throughout the talk today. And I have a disclaimer as well. As many of you may have heard, especially with mammograms and breast cancer screening lately, there's many different medical groups who come out with recommendations on screening, and they can vary quite a bit. My bias tends to be more of a conservative approach, and I think this stems from the fact that the patients I see all have cancer. Many were diagnosed with a screening test, and I also see patients with advanced cancers that never had a screening test. So just to give you a little disclaimer of where I tend to stand on a lot of these screening recommendations. But I think most important, it's best to discuss screening with your primary care provider to determine whether or not you would be a good patient to undergo a certain lab test or screening study. And I should add too, as we're going through here, if anybody has any questions during the talk, feel free to raise your hand, interrupt me. Happy to answer questions as they come up.
So, speaking of that, Dr.
Yeah.
Liss, so from your words there, I take that you believe that the recent criticism of performing mammograms or any other screening test as less frequent would be to the detriment of a person's well-being? Or
I think so.
Okay.
I think so.
More screening, what the heck? It's the worst thing that can happen is that you detect cancer early.
Right, and some of the bias comes from maybe we're over-treating some cancers, which I think was certainly the case. I'll mention prostate cancer during the talk. But now oncologists have a much better understanding of, there's patients that we don't need to treat that are diagnosed with cancer, or we can de-escalate their treatment. Maybe they don't need as many radiation treatments. Maybe they don't need radiation at all. Maybe they don't need chemotherapy. So that oncologist's understanding of managing early stage cancers also plays a role in more active screening, because we're not just treating everybody just because they're diagnosed. So I think that's lost in some of those screening recommendations for more infrequent screening. Does that answer your question?
Thank you.
So to start with, I'll mention what the United States Preventative Services Task Force is, and this is probably the most influential organization that provides screening recommendations. It's created in 1984, and it's an independent volunteer panel of national experts in prevention and evidence-based medicine. And their goal is to improve the health of all Americans by making evidence-based recommendations about screenings, counseling services, preventative medications. I have bolded evidence-based recommendations there because they base their decisions largely on evidence, and what they look for is a clinical trial where half the patients get something, half the patients get something else. You follow those patients for many years. Did that intervention help? We don't have that information on a lot of screening or preventative measures. So for some of those cases, they tend to be, that's where some of the less conservative recommendations come from that group. So they have recommendations on 53 different conditions for adult males, which is far too much to discuss today. So in deciding what to cover, I looked at what are the most prevalent cancers and what are the most deadly cancers for men. It turns out they're pretty much the same. Prostate cancer is the most prevalent. 26% of all new cancer cases in the United States from 2015 were prostate cancer, corresponding to 9% of cancer deaths. Lung cancer, number 2, 14% of cancer diagnoses and 28% of cancer deaths. This is much different than prostate cancer. This is a very deadly cancer. And colon cancer, number 3, 8% and 8% of deaths. Down here I highlighted that this list includes basal cell and squamous cell skin cancers. These are actually far and away the most common cancer diagnosis. There's about, I think the estimate was 5 million skin cancers diagnosed in 2015. These are very curable, either with radiation or with surgery. And those 5 million only corresponded to 2,000 cancer deaths, but I still think it's important to discuss prevention of skin cancer because it's so prevalent. So those were the 4 realms I wanted to get into today: skin cancer, lung cancer, colon and rectal cancer, and prostate cancer. So start with skin cancer. There's a lot of different types of skin cancer, and it's very hard to distinguish, even for dermatologists, oncologists, what's a cancerous lesion, what's not, what's an aggressive cancer, and what's a very easy to treat cancer. These 2 are the most common: squamous cell carcinomas and basal cell carcinomas. The basal cell carcinomas they're described as a pink pearly lesion, where squamous cell carcinomas tend to be a little more ulcerated, or that little divot in there, or kind of a scabbed lesion. That's another squamous cell carcinoma. This easy to treat squamous cell carcinoma looks kind of close to this melanoma right here. Melanoma is a deadly cancer. This basal cell carcinoma is very similar to this lesion right here. That's a Merkel cell carcinoma. Nearly impossible to distinguish until you seek care from your provider and often undergo a biopsy to figure out what this is. But the melanomas and the Merkel cell carcinomas are clearly the ones that we want to identify and treat early. So what are the risk factors for skin cancer? I think we all know the number 1 risk factor: lifetime UV light exposure. And really the biggest areas we see skin cancers are on the head and neck, or your face, your neck, the dorsum of your hand and forearm. So that's the top of your hands and the forearms. Picture somebody going outside in the summertime wearing t-shirts and jeans. What are the sun exposed areas? Back of the hands, skin of the face. That's where we see the most skin cancers. There's some other risk factors as well. Chronic immunosuppression. Patients that have had organ transplants and are on immunosuppressive medications are at risk for skin cancers. Patients with HIV, patients that need chronic steroid use, that increases your risk of skin cancers. Chronic inflammation. These tend to be squamous cell carcinomas. That's what that SCC means. The technical name for that is a Majora's ulcer, but it's not important. And these can come in scars, burns, non-healing ulcers, fistula tracts, or different inflammatory dermatologic conditions that if you have one of those, your dermatologist would certainly know it and be very careful assessing for skin cancers. And smoking, this is on the list of nearly every risk factor for cancer. Viruses can cause it, especially the HPV virus, the human papillomavirus, and arsenic exposure rarely. So right away we get into some controversy with recommendations for screening. Frankly, I didn't know what the USPSTF, or the United States Preventative Services Task Force recommendation was on skin cancer screening until I was preparing for this talk. And what they say is children and adolescents, young adults aged 10 to 24 with fair skin should talk to their doctor about screening and measures to decrease sun exposure. And what this organization does is give all the recommendations a letter grade, just like in school, A, B, C, and D. So A and B are pretty good grades. So they give this a B rating. Surprisingly, for adults older than 24, they say that they give it an I, meaning there's insufficient evidence to recommend prevention of skin cancers, which I found really surprising. And I think this stems from what I mentioned earlier, that this organization likes to have trials where half the patients get one intervention, half get something else. You follow these patients along and see what happens to them. I don't know if there's ever been a trial of adult males that have been randomized to wear sunscreen every day versus a group that didn't wear sunscreen and see what happens. So I think that's where that I comes from. When I read this, I emailed one of my buddies who's a dermatologist, and he was astounded by this as well. So he quickly forwarded me what the American Academy of Dermatology recommendation is, and that's who needs sunscreen? Well, everyone. Sunscreen can prevent skin cancer, and it's estimated that 1 in 5 Americans will develop skin cancer in their lifetime. So again, going back to my more conservative bias, I believe in protecting yourself from UV light and wearing sunscreen. So some other tips for reducing your risk of skin cancer. Again, sunscreen, which I mentioned, which I have some additional information on the next slide. Seek shade, especially when the sun's rays are the strongest. That's 10 a.m. to 2 p.m. And an interesting rule of thumb that the American Academy of Dermatology had was if your shadow is shorter than you are, that's when you should look for shade. Protective clothing, cover your arms, wide brim hats, sunglasses, and extra caution with water, sand, and snow. Water, sand, and snow can intensify the damaging effect of the sun's rays, increasing your chance of sunburn. And it's important to remember, even, we see water and sand in the summertime out here, but snow is a big part of Wisconsin as well. So on a nice sunny day in January, if you're outside, it's still important to protect your skin. And one other recommendation that they have is look at your own skin for signs of skin cancer. And they say that your birthday is a great time to check your birthday suit. Know what your moles look like, know what any skin lesions look like, and importantly, look for change. See if things are growing, see if they're changing shape, color, size, and I have some information on that on an upcoming slide as well. And if you have any question or concern, bring it to the attention of your primary care provider. So here's that slide on SPF. So what the FDA has done recently is mandate that all sunscreens have 3 key pieces of information on it. One is it's got to be broad spectrum. That covers UVA and UVB, and that'll be right on the bottle. SPF of at least 30. That's always got to be on the bottle. And water resistant or very water resistant. This lets you know how long you can be in the water and before needing to reapply. What the American Academy of Dermatology also has noted is people typically don't use enough sunscreen, and their recommendation is to use about an ounce or enough to fill a shot glass to cover the amount of exposed skin. If you're just going outside in t-shirt or jeans, you don't need to put an ounce of sunscreen on your face and your arms. This is more if you're going to be at a beach or sun tanning. So here's another slide I alluded to about looking at your own skin to assess for suspicious lesions. This is known as the ABCD, and they recently added the E. A, look for symmetry or asymmetry. So this is a nice circle, and this is not so. You see how that's a little irregular there. B is very similar. Nice even border, you can draw a line around that. This you can't really, maybe you can draw a line around it, but it's much more irregular. Color, C. Is it all one color, or are there 2 different shades of color? Diameter, that's an easy one. 1/4 inch is the rule of thumb there. And I think the most important one is E. Is it changing? Is it getting bigger? Is it changing color or border? If you notice any of these down here, that's something you need to bring to the attention of your primary care physician. Yep.
When was evolving? When did that become?
I think it was probably when I was in med school we started learning about that. I think that was probably 2005-ish. And when I learned about that in med school, they said that this was a new And it used to be the ABCD of melanoma. I don't know if any of you recall that, but now it's the ABCDE. So what do I do? This, I have to admit, was at the urging of my wife to wear more sunscreen. I was not very good at this, but she's got me putting SPF on my face every morning, SPF 50. So why do I choose my face? Well, this picture right here depicts something called H-zone skin cancers. These gray areas, this is the H-zone. And these are, the H stands for high risk. These cancers are tougher to treat. They have a greater predilection of spreading to nerves in your skin, which can go to nerves that can travel back to the brain. They can involve lymph nodes more frequently than other skin cancers. So these are the ones that cause problems that arise from the skin of the face. These are tougher to treat as well. If you imagine getting a skin cancer right next to your eye, a surgeon's not going to be able to go in and take that out. Radiation can be used very successfully to treat any skin cancers, but especially ones of the face.
So you're talking every morning?
Every morning. This morning, a little dab of SPF 50. And really, if you ever look at, if your wives have a very expensive lotions to prevent aging, they all have SPF in it. And that's probably one of the secret ingredients to prevent aging. So.
Do you do this in the winter?
Well, I haven't started adopting this new lifestyle yet, but I will. It's part of my life now. So.
Is it true that some of these basal cells take decades to come to the surface? Like it stemmed from a bad burn that happened many years ago?
It could, yeah. The frequency of burns in your childhood really increases your risk of, and that's something I'm actually going to allude to right here.
The number of SPF, the higher it is that the more protection, like from 30 to
Exactly.
70?
Yep. Higher the number, the better.
Thank you.
So another thing that I do, my kids, they're outside all the time. They love the water. Whenever they're outside, they have SPF 50 or greater on. And that's because one blistering sunburn during childhood can double your risk of developing a melanoma. 5 or more increases the risk by 80% for melanoma, or non-melanoma skin cancers by almost 70%. So really, it's important for everyone, but kids is far and away the most important. What do I avoid? Tanning beds. The FDA classifies these in the same class as cigarettes. This is a carcinogen. So moving on to lung cancer. 200,000 plus cases every year in the U.S. In Wisconsin, there's 4,300. And unfortunately, the death rate is very close to the number of new diagnoses. These are tough cancers to treat and cure. And what this graph indicates is, so this is 1930 going along the years up until 2011, and the rate of cancers in males. And you can see the rate of lung cancers is far and away the greatest. This is omitting skin cancers, as I mentioned before. So what's the risk factor? Smoking. And one interesting fact about smoking is tripling the number of cigarettes smoked per day triples your risk of lung cancer. But if you triple the duration of smoking, it increases your cancer risk by 100-fold. So that's to say, if you smoke 3 packs a day for 10 years, technically that would be safer than smoking a pack a day for 30 years, even though that's the same number of cigarettes smoked. So even if you're cutting down, still smoking a half pack a day, 5 cigarettes a day, that's still extremely worrisome and detrimental to your health. Passive smoking or secondhand smoking is the next biggest cause of lung cancer. And there's other rare risks: radon, asbestos, pollution. Just being male is a risk factor for lung cancer, and family history. So here's some other numbers on smoking. Percent of smokers that get any cancer, 25%. 1 in 4 smoker will get a cancer. The increased risk of lung cancer in smokers, is at least a 10-fold increase of developing lung cancer. The percent of our lung cancer patients that are smokers, it's almost 90%. It's very rare to see a non-smoking patient develop a cancer. And in fact, it's the non-smokers that do better with treatment than the smokers. And the time to normalize your increased risk after quitting, well, it never normalizes. So my number one recommendation is to avoid smoking altogether. That's the primary prevention of lung cancer. So quit smoking, so secondary prevention, screening for lung cancer. This is kind of a new phenomenon, and I think something that we just started offering at Agnesian within the past few months. And it's, I think, Bill, is that right?
No, we actually,
We've had it for
3 years ago, we started offering this here at AgnesianHealthCare, but, January 1st of 2016, things have changed where Medicare now reimburses for that.
Okay. So, and the reason for this comes from one of those randomized trials. This was an important study published in the New England Journal of Medicine, where they had 53,000 people who smoked 30 pack years. And what a pack year is if you smoke 1 pack a day for a year, you smoked 1 pack year. If you smoked 1 pack a day for 30 years, that's 30 pack years. If you smoke 2 packs a day for 15 years, that's also 30 pack years. So you can see where those numbers come from. And that'll be important later on. But anyways, in this study, half of the patients had a chest x-ray once a year for 3 years, and the other half had a CAT scan of the lung once a year for 3 years. And this study, I think, was published in about 2011, 2012. So this is what prompted lung cancer screening, and this is why it's a relatively new phenomenon. And unfortunately, it took Medicare 4 or 5 years before they'd start reimbursing for this, but now this is part of screening for lung cancer. So what did this study show? Well, it decreased the number of people that would die from lung cancer. So this is up here is the number of lung cancer deaths, and here is the years since they were on the study. And you can see there are fewer deaths in the patients that had the CAT scan versus the chest x-ray. So because of this, that the CAT scan prevented lung cancer deaths, we started offering screening for lung cancer. So how does screening help in decreasing lung cancer deaths? Well, basically we pick them up when they're stage 1 cancers. The cure rate at 3 years is extremely high for a stage 1 lung cancer. So this means if you're diagnosed with a stage 1 lung cancer, what are your chances of being alive 3 years from diagnosis? And it's up to 95% in some studies. A stage 1 lung cancer is something that is just a nodule in the lung. It hasn't spread to any lymph nodes in between your lungs or in your neck. So that's a stage 1. And we treat that with a surgery or with 3 to 5 radiation treatments. Stage 3, on the other hand, the chances of you being alive 3 years after diagnosis is only 25 to 35%. And that involves much more intensive treatment. That's 30 to 33 radiation treatments combined with chemotherapy, sometimes followed by a surgery after that. So what do the medical groups say about lung cancer screening? Well, the USPSTF gives it a grade B. That's a good score. So they stand behind lung cancer screening. This is another very important organization, the National Comprehensive Cancer Network. This is pretty much what all oncologists follow when providing cancer recommendations. And their recommendations are for, see your primary care physician, assess your risk factors for lung cancer, and then if your age is 55 to 74 and smoked 30 pack years, remember that's a pack a day for 30 years, and have quit less than 15 years ago, you should be considered for lung cancer screening. Additionally, if you smoked less than that, 20 pack years, but you had some other risk factors, a family history, COPD, you should also be eligible for cancer screening as well. So what happens when we diagnose an early stage cancer? Well, you could meet Dr. Lilly. He's our cardiothoracic surgeon, and he does an excellent job performing resections of those nodules in the lung. He'll either cut out a little piece of the lung, that's called a wedge resection, or if the patient has better lung function, the better surgery is to cut the whole lobe of the lung out. Your lung has 5 different lobes, and he'd cut out the entire lobe where that nodule formed. And then there's newer techniques to treat these early stage lung cancers, and that's with what we do, radiation. And we do a treatment called stereotactic body radiation therapy. SBRT is the name of it. This is a machine that delivers radiation. It's called a linear accelerator. And basically this moves on an arm around the patient with the patient lying on a table, and the X-ray beam comes right out of this hole right here and aims at the tumor. When we do these treatments, we have to take into account some special considerations. When you're breathing, your lungs are moving up and down. That means that tumor is moving up and down as well. It takes about 3 minutes to deliver one of these radiation treatments. So we want to make sure that the whole time the beam is on and going around the patient, that we know where that tumor is while you're breathing, so it doesn't move outside of the radiation beam and we miss it during treatment. To figure that out, we use something called a 4D CAT scan. Maybe you could pull that up. So whenever we do radiation, we have patients do a special CAT scan over in our department. Hopefully it works. How about, can you hit control?
You have to turn off yours.
It's okay.
So, can you just pause it for a second?
It's lower left.
Down.
All right, that's good. So this is an example of a 4D CAT scan. This is a CAT scan. This is a slice through a patient's lungs, kind of like slicing a patient in like a loaf of bread. This is one lung. This is the other lung. This is the heart right in the middle. That's the spinal canal right back there. This is the front of the patient up here and the back of the patient. Hopefully that makes sense. And you can see this tumor right here. That's a little early stage lung cancer that was picked up by a screening test or for some reason this patient had a CAT scan. There's no way that cancer would cause any symptoms whatsoever. And you can see what the 4D CAT scan will look like. You'll see this tumor moving up and down while we're acquiring one of these special CAT scans. You can play it again. So you see how it goes up and down? This is these two pictures. Oh, can you hit the circle down there to replay it? Yeah. So this is a zoom-in view of this little tumor down here. And what we do is track how that moves up and down so we know exactly where it is the whole time you're breathing, so we can treat that the whole time that you're breathing. Does that make sense?
So does the machine turn off when it goes to a different direction, or does it just follow?
It doesn't follow it. We just make our radiation plan such that the beam encompasses the whole motion of the tumor. We use some other techniques to decrease the motion of the tumor a little bit, but more or less that's what we do. So then we come up with these radiation plans, and this is what an SBRT plan would look like. This is an example of a patient lying flat on a table, and these little colored beams here are examples of the radiation beam coming in from different angles all around the patient, all centered at where that tumor was. And this is what a picture of the radiation plan would look like. This red area is where the tumor is. That's the high dose radiation zone. And these the blue color out here, this is very low doses of radiation. And usually what I mention to my patients is, imagine a room full of people all shining a flashlight on one spot. All of those individual beams are pretty dim, but where they're all centered on that one spot, that's a really bright light. That's the same principle for SBRT. It's a way to deliver really high doses of radiation in 3 or 5 treatments just to eradicate that early stage lung cancer. And I have one more animation to kind of put it all together and show you what the treatment would look like. So this is our treatment machine that we have right down the way. And you can see how it'll move around and shoot the radiation beam right at the tumor. That's the tumor right there. And this treatment takes about 2 to 3 minutes, depending on the plan, and we do this 3 to 5 times. And that's been as effective as a wedge resection or a lobectomy that Dr. Lilly would provide. So if you're interested in lung cancer screening, this is how we do it at Agnesian. We'd have you, you mention it to your primary care provider, and they would send you over to Rebecca. Rebecca will see you over at at the cancer center. In medical imaging. She'd meet you with an appointment and talk to you about lung cancer screening. She'd make sure that you fit the criteria for lung cancer screening, and if so, she would write the order for the CAT scan. You need to have Medicare mandates that you have a provider talk to you about the risks and benefits of lung cancer screening and write and order the test. This is how we do it at Agnesian. We have Rebecca talk to our patients. And this is the Medicare criteria. 55 to 70, no signs or symptoms of lung cancer. Again, 30 pack years. That number keeps coming up. Current smokers were quit within the last 15 years. And you need a written order for the CAT scan. That's a low-dose CAT scan from Rebecca. You only need to do that for your first CAT scan. After that, you can get annual CAT scans just ordered by your primary care provider. And we do this once a year, hoping to detect a lung cancer that we can treat with surgery or 3 to 5 radiation treatments instead of waiting to detect a lung cancer when we're only looking at a 25% chance of cure with very aggressive treatment. So I highly endorse lung cancer screening. Like those curves show, lung cancer is the #1 cancer death in men. If we can screen more patients and catch these early, we're gonna definitely decrease that death rate.
And just add something to that, because
Yeah.
like I said, we've been doing this for over 3 years now. We found early stage cancers due to the screening of CT, so it's been very successful. I can say, like Dr. Liss said, the program that we have in place has been very successful here. Having the MP be kind of that gatekeeper. So providers, they go ahead and send a patient to Rebecca, and then she orders a CT, so any insurance issues that they'll go back to the provider, they go back to Rebecca, so that the doctors are sending patients left and right to us. So it's been very successful, and we found some early stage cancers due to this, which is what we want.
Really, right now, the only time that we see early stage cancers are if a patient had a CAT scan for some other reason, and we see a little nodule, and then we start following that up. That's how we detect cancers now, and they're just found randomly. But hopefully, with more screening, we'll be able to screen for them and detect them early. Next, I want to mention colon and rectal cancer. This is the #3 cancer killer in men. It's on this curve right here. Thankfully, the curve's going down, and that's probably due to screening. What are your risk factors for this? Lack of physical activity, obesity, that kind of goes hand in hand. Heavy alcohol use, heavy red meat consumption. I'm not saying that you have to give up red meat completely and give up alcohol completely, but moderation is important. See it again, cigarette smoking is a risk factor. Just being a man is a risk factor, and if you had a family history of colorectal cancer, that's also a risk factor. There's really good consensus on screening for colon and rectal cancer. The USPSTF gives it a grade A if your age is 50 to 75. Once you're older than that, it's not likely that if you have other health problems and you may not live for another expected 10 years, maybe you don't need to do your colonoscopy after age 75. So that's why it's a grade C. And this just came out last month in JAMA. This is the Journal of the American Medical Association, a very important healthcare journal. And what they said is, the USPSTF has chosen to highlight that there is very good evidence that colorectal screening substantially reduces deaths from disease among adults aged 50 to 75. And importantly, there's not enough adults in the U.S. that are using this effective preventative intervention. So what will I do? Happy 50th birthday colonoscopy. I could book my appointment right now. This is something I'm definitely going to do when I turn 50, and everybody, men and women, should do when they turn 50. Earlier, if there's risk factors, which your primary care provider could talk to you about. There's a lot of different options. This is a busy slide, but basically I just want to highlight that there's many different options for screening. This is testing the stool for signs of cancer, colonoscopy, or other oscopies that don't visualize the entire colon. And there's also CAT scans that you can use. I just want to mention one misconception with CAT scans. It'd be great if you could just go in for a simple CAT scan and that would replace the colonoscopy, but you still need to do that same bowel prep. You still need to basically during a colonoscopy or a CT colonoscopy, they need to fill up the colon with air, which is one of the most discomforting portions of the study. And the difference with a colonoscopy and a CT colonoscopy is the colonoscopy is performed under sedation, where the CT scan is not. So at least if you go with the colonoscopy, you're not going to remember anything. So why additionally do I choose a colonoscopy? Well, sometimes these precancers are flat. You can barely see this little precancer here. The CT scan may not detect that. A colonoscopist would be able to figure that out. And these flat ones are more likely to contain early cancers or cancers compared to other lesions that stick out and kind of look like a little mushroom coming out of your colon. Another reason I think colonoscopies are better is because if we find something, or if our gastroenterologist or surgeon sees the lesion, they can take care of that right away. If you had a CAT scan that showed a lesion, you'd still have to then go back, do another bowel prep, and have a colonoscopy to treat whatever was found. And what I mentioned before, the colonoscopy looks at the whole colon. This whole colon is at risk for cancer. Other tests like the sigmoidoscopy only go up to like right there. So really getting a whole full colonoscopy is, I think, the best test. Kind of mentioned this. And I think I'll just skip this slide for now. Regardless of the test you select, it's important to the key is early diagnosis. Again, this curve right here is showing what the survival rate is for patients with very early colon cancers or advanced stage 3, stage 4 when it's spread to lymph nodes. When we detect them early, you have a much greater chance of living many years versus detecting it late. So finally, I'll want to mention prostate cancer. This is still the number 2 cause of death in men, which is important to remember. What are the risk factors? Well, most of these are unmodifiable risk factors. Your age you can't change, your race you can't change, your family history you can't change, and your genetic syndromes. That's all part of who you are, and you can't modify it, unlike smoking or alcohol, red meat consumption. So this is very controversial. Here's our USPSTF, and what grade do they give PSA screenings? That's a blood test to detect prostate cancer. They give it a D. They say don't do it, which I disagree with, and I'll get into that. There's other recommendations. What does the National Comprehensive Cancer Network say? Well, they say talk to your primary care physician about it, and if you're age 45 to 75, they still say to get a PSA, and based on what the number is, you can figure out how frequently to perform the next PSA. This is very similar to what the American Urology Society says. Again, for men 55 to 70, talk to your primary care physician to discuss the benefits and risks. So why do I favor PSA screening in healthy men? Well, number one, healthy men is important. Prostate cancer is different from lung cancer. It tends to progress very slowly. There are exceptions to that, but that's generally the rule. If a man has a lot of other comorbidities, COPD, kidney disease, on dialysis, there's no reason to undergo PSA screening. But for a healthy man, we could detect a cancer. I'll mention, so this Preventative Services Task Force uses evidence to make their recommendations, and there are significant flaws in the evidence that they use to justify the omission of PSA screening. And something that I mentioned to Steve Little earlier is this principle of really figuring out who needs treatment. We now have a better idea of something called active surveillance. There's many men that we diagnose with prostate cancer where we don't do anything at all. We just follow them along, continue to do PSA checks, occasional repeat of biopsy, and oftentimes those prostate cancers stay at a very early stage, and we don't need to subject that man to any treatment, which is the best way to avoid side effects. If you don't need treatment, you're not going to have any side effects of treatment. And finally, our technology is getting much better. As our technology improves, we're decreasing the toxicity of surgery, of radiation. This improves the risk to benefit ratio. If the treatments are less risky, then the benefit of treatment is more important. And two of the things we have here at Agnesian are the special MRI, which we use for prostate cancer, and radiation techniques, which can spare normal tissues and improve side effects. So this was the flawed study, and I'll just mention a couple of key points about it. This was similar to that other study. A lot of patients, 76,000 men. They were supposed to be randomized, half getting a PSA test, half not getting a PSA test. Follow them for many years and see what happens. Well, the problem with this test is about half the patients that were in the no PSA testing arm had a PSA test, and not all the patients in the arm that was supposed to have a PSA number got tested. So really what this ends up being is both groups of patients had PSA testing. So if both groups of patients are getting the same intervention, you're never going to detect a difference in the outcomes. And that's what happened. This is the survival rate, the likelihood of prostate cancer death between the group that did not get PSA testing and did get PSA testing. And these lines overlap, meaning there's really no difference, or this study didn't show a benefit in PSA testing. But I already alluded to why I think that happened. It's important to remember too, prostate cancer is still the number 2 cause of death in men. We see patients all the time with metastatic prostate cancer when they're diagnosed. These are men that if it could have been detected earlier, we'd have a greater chance of curing them and decreasing this number. And lastly, I'll touch on technology a little bit here for the last couple of minutes. So this is another CAT scan. This is a slice through a patient's pelvis, again like a loaf of bread, slicing through. And here you can see the hip bones. That's the one femur right there. That's the other femur. And what I just want you to appreciate here is this is the prostate, and it's basically probably looks like a big gray blob. That's what it looks like to oncologists and radiologists as well. We don't get a lot of information from a prostate CAT scan. We just know generally where the prostate is. We've developed improvements in looking at the prostate, and this is a 3-Tesla MRI. I got this slide from Dan Maxud, one of our prostate radiologists here at Agnesian. And these are the kind of pictures we get now. It took me 4 years of med school and 5 years of radiation oncology residency to understand what's going on in these pictures. So I don't expect you guys to look at this for the first time and really grasp what's going on. But hopefully you can see a bit more detail here. This isn't a gray blob anymore. There's a lot of different things that we can see in this picture, including this little dot right there. And on other pictures that we take with our MRI, you can see it lights up white there. It's a black hole on that picture. And on this series, it shows up red. That little spot could harbor a very high-risk prostate cancer or more aggressive prostate cancer. In the past, when a man's PSA was going up, we'd send him for a biopsy, and the urologist would stick 6 or 12 needles randomly in the prostate to see if there's any prostate cancer. I know it sounds like an awful procedure, but it's done under a little bit of sedation, and we get men through it. With MRI, this is the spot you want to stick a needle. That could be where the high-risk prostate cancer is. That could be the cancer that we need to treat versus one of those early stage cancers where we can just watch and not offer any treatment. So this technology is helping us better identify who needs treatment. And this was a study that I was part of during residency, and we just published it in the Lancet this year, looking at vessel-sparing radiation, improving erectile function after prostate radiation. Basically, what we did with this study is, we know what the prostate anatomy should look like from cadaver studies and anatomy textbooks. This is what we expect to see. With a CAT scan, when you're just looking at that gray blob, you can't appreciate any of this anatomy. Veins and arteries that are important for sexual function, nerves, muscles that are important for continence after radiation or surgery. With MRI, we can see all this stuff now, and we, in this paper, we demonstrate how we can use the MRI to better select patients that should be surgical candidates or radiation candidates, and how we can spare these critical structures from surgery or radiation. An example is here. So this would have been a gray blob on a CAT scan, but here you can see this prostate cancer is actually invading through muscle right there. If this patient were to go to surgery, they would certainly need radiation afterwards. So if we see this on an MRI, we can say to the patient, go to radiation up front. It'll be equivalent, and it'll be the right treatment for the patient, instead of subjecting them to the side effects of surgery and radiation. Same with, these are also pictures from our study. This is identifying location of some of the nerves and arteries that are important for sexual function. And on a CAT scan, you can't see those. With MRI, we can identify them, and we can avoid radiation dose to these regions. Furthermore, we can see patients that, usually the nerves and arteries are in a little bundle right behind the prostate, like that picture. And the surgeon can cut around the prostate, take it out, and leave these nerves and arteries behind. Some patients have nerves and arteries that line the whole prostate like that. And if the surgeon cuts out that prostate, the patient won't have any sexual function afterwards. And this is just a last picture. This is one of those muscles that's important for urination. It's important for continence. If there's a big distance between the prostate, which is in blue here, and this is a nice long muscle, this patient will be an excellent candidate for surgery or radiation. If you have a little short muscle, like this patient has right there, that surgeon's going to cut most of it out when they do the surgery, and the patient will be at a greater risk of incontinence. Furthermore, when radiation was planned only with CAT scans, in the past, we'd draw a circle around this whole thing and treat everything, because we couldn't see this muscle on a CAT scan. Now we can actually figure out where the prostate is, where the prostate cancer is, and not treat all this, decreasing toxicity from treatment. So a couple other notes here. Agnesian screens for cancer every year. It's every April, and we offer a lot of different screening interventions: skin cancer, oral cavity cancers, testicular cancers, prostate cancers, colorectal cancers. I got some of these numbers from Heather. We've been doing this for 20 years. I've participated in one so far, but because I've been here a year. So far, over the past 15 years, we've screened 1,500 patients, and this should occur again sometime in April. I've included some websites here in case anybody has additional questions or could access this afterwards. These are good websites to learn more about screening. And finally, I'm happy to be part of the team now. We'll have to take a new picture, I guess. But really, I'd hope that none of you have to be a patient of ours. I hope primary prevention works, and you can prevent cancers before they happen. If you need to come to the cancer center for treatment, I hope that it's an early stage cancer where we have excellent cure rates. And I just want to include one more picture of this is my family. This is my wife, Tammy. There's Sydney, Violet, and Hazel at the Elkhart Lake Parade this year. My goal is to grow old with Tammy and see my kids grow up and see their grandchildren. So that's my motivation for preventing cancer, not smoking, modifying risk factors, and getting a colonoscopy when I'm 50, getting my PSA tested when I'm 55. I just hope that you all and the men in your life can find similar motivations to undergo screening tests. And with that, I think finished 5 minutes ahead of time, so if there's any additional questions, I'd be happy to take them. Yes?
Do you see the role for surgical intervention in prostate cancer shrinking over time?
I would say in general, yes, and I think it's the role of radiation maybe going down as well. That's because we're identifying men that don't need treatment. That's been the most important thing that we figured out. We can observe these men for many years and often not treat them. I think the role of radiation instead of surgery, when we pick up findings like I showed on that MRI, that's helping to guide men into the right avenue as well. Our urologists do a great job of getting us involved and seeing patients early in the community. There's many patients that never see a radiation oncologist until after the surgery, and we need to offer treatment because the cancer involved muscle or was way too aggressive and should have been treated with upfront radiation.
If there's not an expiration date on the sunscreen, the lotion and stuff, how can you tell if it's still good? Like, do the stores just pack away at the end of the season and bring them out? You've got little guys. How can you tell if it's still open?
I don't know. I've never looked for an expiration date on a bottle of sunscreen. I'd have to get back to you on that as to figuring out how long a sunscreen is still useful. Sorry.
For that April screening, is that something that like people would have to set up through their primary care, or is that?
No, you just need to. Let's go back to that. I think all you need to do is call the cancer center and register ahead of time.
Yeah, my order went up and it's out with papers and once before payment, so just call them and we'll just set up them.
You can also register online. There'll be a link when we do our marketing materials. You can go and register and pick the time.
It's Agnesian.com/LivingSmart.
Any other questions? Should we move on to the drawing? It's probably
Just a comment. Thank you very much, Dr. Liss. You're a blessing to this community and to this organization. We're fortunate to have you and your family here. And what I want you to do is work with Holly Brenner. Have you ever seen those plasticized lungs? Where there's a gentleman, I can't remember his name, but they take actual organs and they plasticize.
Oh yeah, yeah.
Okay, so what I want is, I want one of those normal lung, smoker's lung. And I want to put it right in our lobby and say, which one do you want to be?
Yeah.
You cannot believe the prevalence of smoking in this community. And our associates, we have associates who have had cancer before that are still smoking. Are you kidding me? So we got to do a better job of that, and I appreciate your
Yeah, I feel as privileged to be part of the Cancer Center, and I definitely could work with Holly and getting some more stuff out there to help decrease smoking among our associates.
Thank you very much.
Excellent, thank you.
Thanks.
Everybody have their green slips in?